Here now to expand on a handful of gastrointestinal cancer abstracts is Dr. Manish Shah, Chief of Solid Tumor Oncology and Associate Professor of Medicine at Weill Cornell Medicine, NewYork-Presbyterian Hospital. Hi, Dr. Shah. We're so happy to have you here today. Thanks for being here.
So happy to be here. Thank you.
So, the Polio Trial is one of the most talked about abstracts in pancreatic cancer at this year's meeting.
Yeah.
So, what can you tell us about it so far?
Yeah, so this in many ways is a practice-changing study. So the Polio Trial was a study specific in pancreas cancer in patients who have the BRCA1 or 2 mutation. And that occurs in about 5 to 10% of pancreatic cancer patients. And we know that these patients, they have a defect in DNA repair, and they likely do benefit from a PARP inhibitor. In the Polio Trial is the olaparib PARP inhibitor. And this was a randomized study in patients who received FOLFIRINOX, and if they didn't have disease progression, they had stable disease or response, they were randomized to best supportive care or olaparib. And there was a significant improvement in patient outcomes with the olaparib arm. So that was in fact a positive study. So it does a couple things. It improves that. It provides a proof of concept that targeting BRCA in pancreatic cancer is important and effective. So I think that's a critical thing. Based on that study and other studies, now ASCO guidelines and NCCN guidelines have recommended that anyone with pancreatic cancer should get genetic testing for BRCA as well. So those are two key features of the study.
Good. Those are some great points. Thank you. Now, can you tell us a couple of things about the GO2 trial that's evaluating elderly and frail patients with advanced gastroesophageal cancer?
Sure. The GO2 trial is a very important study. A lot of patients that we see are elderly and frail, and they may not meet criteria for standard treatments. You would not give someone who's older and frail, has comorbid conditions, FOLFIRINOX, for example. So this was a study that looked at chemotherapy reduction and less intensive therapy, and it did show that there was an advantage with reduced toxicity without compromising efficacy. So that was a key aspect of the study. The GO2 trial, actually though, uniquely, it changed to a superiority study sort of midway through. So that was something that the discussant brought up this morning, which was of interest.
Okay. Now, we also saw data from the phase 3 KEYNOTE-062 trial with pembrolizumab with or without chemotherapy versus chemotherapy for advanced gastric or gastroesophageal junction adenocarcinoma. So can you speak to these data and why it's important?
Sure. So immunotherapy in GI cancers is still evolving, and the KEYNOTE-062 trial is a first-line study of 3 arms. There was a standard chemotherapy arm of FOLFOX. There was FOLFOX plus Keytruda and Keytruda pembrolizumab alone. It was limited to PD-L1 positive patients, which is about 50 to 60% of gastric cancer. And there were a couple different questions that were asked. Does immunotherapy plus chemotherapy improve survival, both progression-free and overall survival versus chemotherapy alone? And also, does Keytruda as monotherapy, is it equivalent or at least non-inferior to chemotherapy either in progression-free or overall survival? And the study was complicated as it is. It did achieve at least one positive result. So the Keytruda monotherapy arm was non-inferior to chemotherapy in the PD-L1 positive group. So that's very important. Some key things to think about in this study, though, is that when we're doing a non-inferiority study, we look at how much worse could the experimental arm be and still be considered equivalent. And the hazard ratio for that was 1.2, which is acceptable, but what it means is that up to, your patients could be doing up to 20% worse with Keytruda versus chemotherapy, and I think individual physicians and patients would need to think, is that something that's meaningful to them?
Good, great points. Now, another trial looked at survival outcomes with laparoscopic versus open resection for patients with gastric cancer who have liver metastases. So can you tell us a little bit about that?
Yeah, so this was a study of laparoscopic versus open resection for patients with gastric cancer. And this is an important study because although there are previous studies that suggested that laparoscopic resection can be done, it's technically challenging because the stomach is in the upper part of the body, and there's lots of things that need to happen to take out the stomach safely. This was not with liver metastases, but it did show in a very large randomized study that there was no detriment in outcome with laparoscopic surgery. So I think if you're well trained, if you have experience in laparoscopic technique, then you're perfectly reasonable to do a laparoscopic technique and offer that benefit to patients.
So what are some other GI cancer studies that are being presented this year that you're really excited about?
Yeah, so the GI field has really evolved quite a bit. We see actually a very exciting study in cholangiocarcinoma. This was the follow-up to the gemcitabine cisplatin study, which demonstrated benefit in the first-line setting. There remains a question what to do after patients progress on gemcitabine and cisplatin. So there was a large study comparing FOLFOX versus best supportive care or active supportive care. And what we found out is that FOLFOX does have activity. Patients had a better outcome, progression-free survival and overall survival, and I think that's the new standard.
So let's take a look at now all these data that we have that's been presented at this year's meeting. What do you think that tells us about the future of the GI cancer paradigm overall?
Yeah, so in the last several years, thousands and thousands of patients have been put on clinical trials in GI cancers, both colon cancer and upper GI cancers. We talked mostly about upper GI cancers here, and it's really exciting that we are making advancements. I think that we feel like there's more to do, obviously, but we do see incremental benefits with the trials that we're doing. So we really thank all the patients and all the participants in the trials.
Great. Well, Dr. Shah, thank you so much for coming by today. Really
Absolutely.
happy to hear your insight.
Great. Thanks for having me.
Thanks.